Good morning, and welcome to this session, the lymphoma session post coffee break. So hopefully all of you have been well refreshed. And for those making yourself through, please have a seat, and we'll kick off with this session. So my name is Francis Sundram. I'm a nuclear medicine physician at Southampton. I'm one of the co-chairs. The other chair is there sitting, standing and ready to deliver her talk, Sally Barrington. Sally is a UK NIHR professor of research at Guy's and St. Thomas's, and she's best known for successful implementation of international PET-CT guidelines, of which we know is the Deauville score. And she's involved in a number of clinical trials, including the UK PET core imaging lab at St. Thomas's Hospital. And she's here to talk to us today about lymphoma in terms of PET-guided response, the evidence base. Thank you, Sally.
Thanks very much, Francis, and thank you also to the organisers for inviting me here today to talk to you about this topic. These are my disclosures. So, diffuse large B-cell lymphoma, Hodgkin's and follicular lymphoma together make up about 90% of the lymphoma subtypes that we see. Hodgkin's and diffuse large B-cell are regarded as aggressive lymphomas where the aim of treatment is cure. And it's really in these two subtypes that most of the evidence base is regarding PET response-adapted treatment. So I'm going to concentrate on these two during the talk. Now, we've known for a long time that during chemotherapy, if you have a PET scan as an early readout of chemosensitivity, then patients with a PET negative scan who achieve complete metabolic response have much superior outcomes to patients who have a PET positive scan where the disease is still present in response to largely ineffective chemotherapy. And so knowing this, that gives us the logic for testing PET-guided therapy. And in the trials to date, what's been tested has been whether or not we can escalate therapy for patients with a PET-positive scan who are not responding in order to improve their chances of cure. And importantly also, in those patients with the green light of an early PET-negative scan, to see if we can de-escalate therapy in order to reduce toxicity. And the earliest trials were done in Hodgkin lymphoma, which, although it's not a common cancer, is an important one because it's the commonest cancer in teenagers and young adults. And we know that some 15 years after treatment, more patients die from the side effects of treatment than from the Hodgkin lymphoma itself. Now, we can divide Hodgkin's into early and advanced stage. Advanced includes patients with stage 3 and 4 disease, but patients with stage 2 and B symptoms with other adverse features are often also treated with advanced stage protocols. We can further subdivide early stage into favorable and unfavorable prognosis according to specific clinical criteria which are laid down by European and German Hodgkin study groups. Now, these three trials looked at whether or not we could omit radiotherapy for patients with early-stage Hodgkin lymphoma who were treated with ABVD chemotherapy. They had different entry criteria. So if we look at these two trials on the left, these enrolled patients with better prognosis compared to the H10 study, which enrolled patients with both favorable and unfavorable disease characteristics. Now, the study schema look a bit complicated, but all these three had a common question, which was, if we look at the PET-negative patients, they were all randomized to either receive no further treatment or radiotherapy following an early PET negative scan. In the HD17 trial, patients with only unfavorable disease were included, and so the study design meant that patients received ABVD chemotherapy, but in addition, patients received 2 cycles of escalated BRCOP, so more intensive chemotherapy up front, but with the same question: could we randomize patients who had an early PET negative scan to receive no further treatment instead of radiotherapy? What did the results of the trials tell us? Well, they told us that the risk of relapse was increased in patients with favorable disease or no mediastinal bulk by 6.3% in RAPID, up to 11.9% in the H10 study. The advantage of radiotherapy, however, was less in the patients with unfavorable disease, in whom the risk was increased by 2.5% in the H10 study. But we should bear in mind that these unfavorable characteristic patients received more chemotherapy than the patients with favorable disease. In the HD17 trial, where patients received more intensive chemotherapy up front, there was no increased risk by leaving out radiotherapy at the end. And so I think what this suggests is that there may be a trade-off between using radiotherapy and chemotherapy to get patients into remission. The benefit that's seen from radiotherapy in the PET-negative patients is mainly in patients with favorable disease who have only 2 or 3 sites of disease. Interestingly, there is no benefit in overall survival whether patients receive radiotherapy or don't with a negative interim PET scan. And that's because for those patients who relapse, second-line treatment is extremely effective. And maybe the early relapse rate in PET-negative patients could be offset by fewer late effects if fewer patients have radiotherapy. But it'll take a little while before we can report those outcomes. Currently, though, I think as a result of these trials, patients have a choice whether to receive radiotherapy or not, which will be informed by their age, their disease distribution, what their prognosis is, and of course, their personal preference. In the H10 study, apart from asking a de-escalation question, there was an escalation question. Should PET-positive patients be switched from the less effective ABVD to the more effective escalated BRCOP? The 5-year progression-free survival improved for patients, increasing from 77.4% to 90.6% when treatment was intensified for PET-positive patients. And this approach has now become standard in many countries. Interestingly, in the UK RAPID trial, patients had a very similar 5-year PFS if they had a Deauville score of 4 and were treated with ABVD and radiotherapy rather than the more intensive escalated BRCOP. But again, I'll draw your attention to the fact that these were patients with better prognosis than the patients in H10. The patients with a Deauville score of 5 have significantly worse prognosis, with a 5-year progression-free survival of only 62%. So moving on then to advanced stage Hodgkin lymphoma, the options at the diagnosis for patients include escalated BRCOP or ABVD chemotherapy. Escalated BRCOP is more intensive, it has higher efficacy, and the 5-year progression-free survival is somewhere around 5 to 10% higher than ABVD. Because of its intensity, it's usually reserved for younger patients aged 60 or younger. Downsides, it has more acute hematological toxicity. It's more likely to affect fertility, particularly in women aged 30 or over, and higher rates of second malignancy have been reported. So the same question really as we were asking in the H10, as many patients can be cured with ABVD, can patients start with ABVD and switch to escalated BRCA if they're PET positive early on? So there were 3 trials that tested this question, and what they all showed was that the progression-free survival improved when compared with historical controls. So PET-positive patients had a 3-year progression-free survival ranging from 60 to 67.5% when treatment was intensified based on a positive PET scan. And this is now also a standard of care in several countries. But remember, it's still inferior to starting with escalated BRCA from diagnosis. So in the AHL 2011 trial, they thought, well, we'll do it the other way round. We'll start with escalated BRCA, and then if the PET scan is negative, we'll de-escalate to ABVD. The 5-year progression-free survival of the PET-guided approach was not inferior to the non-PET arm, suggesting that this is indeed a reasonable option. Note, like the other trials, though, the PET-positive patients continue to have significantly inferior progression-free survival to the PET negatives. I'm going to go back to the RATHL and the JITL trials because they also asked a de-escalation question. And what RATHL showed was that for early PET-negative patients, it was safe to drop the drug bleomycin after 2 cycles. Bleomycin can cause lung toxicity, and in the RATHL trial, those patients had non-inferior survival, and they also had fewer side effects, particularly less incidence of febrile neutropenia. The JITL trial showed that it was safe not to give radiotherapy for patients who had bulky disease, provided they became PET negative early on. The HD18 trial treated all patients with escalated BRCA, but looked at reducing the number of cycles. And what they found was that for patients with 4 cycles of escalated BRCA, the survival was not inferior, patients had less organ toxicity, and there were no treatment-related deaths in patients who had 4 rather than 6 or 8 cycles. Now, all those were about interim or early PET. This study, the HD15, looked at patients who had a residual mass at the end of treatment after being given escalated BRCA, and the question was, did these patients need radiotherapy or not? And the overlapping curves of the green and the blue line show that those patients that had a complete response with no residual mass, and those patients that had a residual mass that was PET negative who did not receive radiotherapy did just as well. So again, this is a reasonable approach. So in summary, what those trials showed us was that de-escalation, according to an early or end of treatment PET scan, is safe with fewer side effects for the patients. And with all these de-escalation strategies, the overall survival for patients with a PET negative scan is excellent. And I want you to remember again that in Hodgkin lymphoma, there is very effective second-line treatment. So there's now a variety of options that patients can be offered with Hodgkin lymphoma, and these are the most recent UK guidelines. But I think what's important is that all of these approaches are guided by PET, and that the pros and cons of each approach can be discussed with patients individually according to their risk-reward balance. So moving on then to diffuse large B-cell lymphoma, up until now there's been very little response-adapted treatment, because although we know that interim PET is prognostic after 2 cycles of R-CHOP chemotherapy, which is often given, in the PETAL trial, which had 862 patients with aggressive B-cell non-Hodgkin lymphoma, changing treatment did not improve outcomes for either PET-negative or PET-positive patients. And this is partly because there is really not very, or until now, there haven't been very good alternatives to R-CHOP chemotherapy for about the last 20 years. This was a study, the GAIN study, whereby actually the study question was to see whether or not the antibody obinutuzumab was better than rituximab with standard chemotherapy, which it turned out it wasn't. But they did use a PET-guided approach with success. So although the study schema looks a bit complicated, just bear with me. Those patients that had a PET2 negative scan continued on standard chemotherapy. Those patients where the PET2 was positive, but the PET scan became negative after cycle 4, were given high-dose chemotherapy and autologous stem cell transplant. And those patients that remained PET positive throughout were offered salvage therapy. Patients with a PET2 negative result had excellent progression-free survival of 90% at 2 years. But the PET4 negative patients, who you will remember had intensified treatment with autologous stem cell transplant, also had very good progression-free survival of 84%. Whereas, again, the PET4 positive patients still have inferior outcomes, suggesting that this group needs alternative treatment. So it seemed that the adverse PET2 result could be overcome with intensification, and a PET-guided approach resulted in good outcomes for PET-negative patients. This study in patients with limited stage diffuse large B-cell lymphoma was presented at the International Conference on Malignant Lymphoma last year. And the main question here was, if patients were PET negative after 2 cycles, could they have fewer cycles of chemotherapy, reducing from 6 to 4? Again, overlapping survival curves for progression-free survival in the experimental and the standard arms suggest they can. And although it's not been published yet, I suspect that 4R-CHOP may well become the new standard of care for patients with limited stage diffuse large B-cell lymphoma if they are PET2 negative. So all the work so far has been done in response-adapted treatment, but I want to give you a glimpse of where I think we're going now with risk-adapted treatment. So last month, we published in the Journal of Clinical Oncology a study in over 1,200 patients with diffuse large B-cell lymphoma, where we devised and validated a new prognostic score. So before the patients had any treatment, the best prognosis was given by combining the metabolic tumor volume on PET with the patient's age and stage. And we call this the International Metabolic Prognostic Index, which performs better than the standard IPI, which is comprised of 5 clinical risk factors, which is currently used to assess prognosis for treatment. The beauty of this score is that it's also a continuous score. So we don't have to lump patients into 4 categories like this. We can give patients an individualized risk estimate. So here's a patient in the study. You can already see the patient has large tumor volume. In fact, this patient has over 4 liters of tumor. They're age 61, stage 4, and the probability of this patient being alive and free of lymphoma at 3 years is just 31%. And this is a regression formula which can be applied in this sort of simple Excel tool using that link. Let's contrast that with this patient who has less tumor, they're younger, early stage, and their probability of being alive and free of lymphoma at 3 years is over 80%. Now, I think this could be very important because I think this gives us the opportunity when designing clinical trials to select those patients with only the very worst prognosis to actually trial the new treatments that are becoming available in this disease, such as CAR T-cell therapy and bispecific antibodies. And we've opened recently a trial, Remodel A, which is a prospective study in which we're measuring metabolic tumor volume and we're looking at the effect of interim PET combined with circulating tumor DNA, the so-called liquid biopsy. This is one of 5 trials that are open currently in the UK, looking at response adaptation in lymphoma and risk adaptation. And I think I'd like to thank very much all of those in this room and in the wider UK nuclear medicine community who are contributing to these trials and the trials that have been in the past. It's something we do in addition to the day job. I'm always very well aware of that. But I think it is meaningful. I think in the UK we have led on some of these trials, and as a result, PET-guided response is now standard of care in Hodgkin lymphoma. PET-guided therapy is coming in diffuse large B-cell lymphoma. I believe risk-guided therapy with PET will be the future, and I want to say, please continue, therefore, to carry on helping us with the clinical trials. And I'd like to acknowledge my colleagues who work with me in the UK PET Core Lab, all the patients and their families and the investigators, and the wider PET Centre team at Guy's and St Thomas's and King's College London, and you very much for your attention. Thank you.
Thank you, Sally, for that excellent and comprehensive overview, and congratulations for the publication and all the hard work that your team is doing, as well as the wider nuclear medicine community in the UK. So I think we've probably got time for 1 or 2 questions at this juncture. There are a couple of mics around the auditorium if anybody has a burning question. Please feel free to come down. If not, Sally is always available later, so please feel free to sort of approach and have a chat with Sally. So thank you, Sally, for that.